The anatomy of the abdomen is very critical and crucial to understand all the GIT questions. So, the abdomen anatomy is overlapping with all GIT questions either in the pediatric or the GIT and hepatobiliary as well the colorectal. So, take care of this chapter and understand the anatomy well, and its question is very common by the way, and you will understand the scope by the way. So, let's go for it together. A very famous question about surgical access. It's very famous. So we have an aneurysm located juxtarenal location and surgical access is required to the neck of the aneurysm. So how can we improve this access? Simply by dividing the left renal vein. We all know that the left renal vein will be stretched over the neck of the aneurysm in this location and it's not frequently divided. So, this adds to the nephrotoxic insult of the juxtarenal aortic surgery as a suprarenal clamp is also often applied. So, deliberate division of the cisterna calli will not improve the access and will result in chyle leak by the way, and this is not needed by any surgeon intraoperative to have a chyle leak. So division of the transverse colon as well will not help the patient at all and would result in a high risk of graft infection. So as well as the division of the superior mesenteric artery is pointless for the juxtarenal process. And by the way, the superior mesenteric artery is very important, not easily to be lost. So the left renal vein will be stretched over the aneurysm and it will be divided to give better access. Dear great surgeon, take care. The vertebral level is very frequently asked in the MRCS exam, and at first you might find it an irritable question, but with time you will find it a winning horse in the exam, and you will know it all. It's very important to learn from MRCS style that the clinically applied anatomy is important and it's all about clinically applied anatomy. So when he tell you about a scenario about a soldier who had a shot in the abdomen and among various injuries, a major disruption to abdominal aorta, there is a torrential hemorrhage and the surgeon decide to control the aorta by placing a vascular clamp immediately inferior to the diaphragm. So, which vessel will be injured in this maneuver? The clinical applied anatomy here is asking you about the very first branch from the descending aorta just below the diaphragm. And the very first branch below the diaphragm here will be the inferior phrenic arteries. So, the first branch of the abdominal aorta is the inferior phrenic artery. Those are at greatest risk, while the superior phrenic arteries lie in the thorax. The potential space of the level of diaphragmatic hiatus is potentially useful site for aortic occlusion. However, leaving the clamp applied for more than 10 to 15 minutes usually leads to poor outcomes. So take care. Dearest great surgeon, take care. There are three unpaired branches for abdominal viscera. Again, there are three unpaired branches for abdominal viscera, including the celiac axis, superior mesenteric artery, and inferior mesenteric artery. The branches to the adrenals and the renal arteries, as well as the gonadal arteries, are paired. You have two gonadal arteries, two renal arteries, and two adrenal arteries. But we have a fourth unpaired branch of the abdominal aorta, which is the median sacral artery. But this doesn't directly supply the abdominal viscera. So read the question again and take care. He is asking about the arterial supply for the viscera from the abdominal aorta and unpaired. So we have the celiac and the superior mesenteric and inferior mesenteric artery, while the sacral artery is not directly supplying the abdominal viscera. So we have only three unpaired supplying abdominal viscera from the aorta. Take care. The medial sacral artery supplies the lumbar and sacral vertebra, as well as the coccyx and anal rectal junction in the posterior part of the rectum. So it's not directly supplying the viscera. mainly the lumbar and sacral vertebrae as well as the coccyx, while the inner rectal junction in the posterior part of the rectum had branches from the sacral artery. There is great surgeons. Take care. The rectus abdominis is not the rectus sheath. It's within the rectus sheath. The rectus sheath is a bag containing pyramidalis, rectus muscle, as well as the superior and inferior epigastric arteries and veins. Take care. The trick in the exam regarding the rectus sheath is that there is no muscle cutting in Femoral. So you can only cut the rectus sheath. And know that the rectus sheath below the umbilicus has anterior rectus sheath. There is no posterior rectus sheath. So the layers will be cut during Femoral incision, during cesarean section will be the rectus sheath, and splitting the rectus abdominis, and you will find the fascia transversalis. Here you can cut it, and then the peritoneum, and this will be cut as well. But there is no muscle cutting. There is no cutting for the rectus abdominis muscle itself. Take care. In hernioplasty, we use a tension-free polytetrafluoroethylene mesh. It's a monofilamentous mesh. So take care. The mesh is put below the cord, not over the cord, and not over the external oblique. It will be below the external oblique, below the cord, or the fascia transversalis. And to be precise, especially if you are a general surgeon, many like to put it below even the fascia transversalis, to be over the peritoneum. And then it will be called subplay, because it's below the fascia transversalis and over the peritoneum. But most of the surgeons in practice, they tend to use the mesh to be overlay. Overlay means over the fascia transversalis, but no one put it over the external oblique. Take care. Anal sphincter is composed of external sphincter and internal sphincter. The internal sphincter is the one not related to the continence, while the external sphincter is important for the continence. If you cut the external sphincter, it will cause incontinence for the patient. And believe me, it's important for any patient and any person to have continence for his own will. So, during anal fissure, you will have to do sphincterotomy. Sphincterotomy, lateral sphincterotomy, is done via dividing the internal sphincter, not the external sphincter. This is to preserve the continence of the patient. But in young females, we tend to inject local diltiazem as a trial before any surgical intervention. So there is no lateral sphincterotomy for young females before trying out the diltiazem. It may work with them. And remember that the external anal sphincter is innervated by the inferior rectal branch of the pudendal nerve. Its root value is S234, which keeps the poop off the floor because it's responsible for the continence. These great surgeons, let's continue together the abdomen clinically applied anatomy for MRCS. We all know that the IVC, the inferior vena cava, lacks valves. But why the valves are lacked in IVC, and what is the importance of this information? The information about the lacking of valve in the IVC is clinically when it's cannulated during cardiopulmonary bypass using separate CVC and IVC catheter, such as when the right atrium is to be opened. So take care. Again, IVC has no valves. There are some rare syndromes, but you have to be aware of in the abdomen, like the median arc ligament syndrome. It's a rare condition which median arc ligament compresses the celiac artery. This impairs the blood flow to the liver, stomach, and other organs. The symptoms would be abdominal pain, unintentional weight loss, and abdominal puree, abnormal sound. It's often misdiagnosed and ultimately confirmed by vascular imaging. Always treatment will be surgical release of this median arc ligament band. The median arc ligament is a fibrous arch that connects the diaphragmatic crura to form anterior margin of the aortic hiatus. In 10 to 24% of the cases, it's low-lying and cross over proximally per portion of the celiac artery. And mere non-absorptive anatomic variant of compression of the celiac artery result in mesenteric ischemia. The median arc ligament syndrome is very rare, yet you have to be aware of it. MALS. It calls also Dunbar syndrome or Harjola-Marable syndrome. Again, Dunbar syndrome or Harjola-Marable syndrome due to compression of the celiac trunk by the medial arc ligament. It may lead to mesenteric ischemia. Again, regarding embryology, should I study embryology as a whole from a textbook like Lang or even a short note for embryology? No. You have to take the idea from in between the questions because it will be overlapping with many chapters and you will know it all. Just follow the lead and take each question and take your notes, side notes for embryology, and that's it. About 75 ideas you will be taken along all the MRCS exam study routine, and you will know it by your exam, inshallah. So let's take a glimpse about embryological origin of pancreas, which is very common question in the exam, by the way, and very common record. The pancreas develops from the ventral and dorsal endodermal outgrowth of the duodenum. Endodermal outgrowth of the duodenum. And the ventral arise close to or in common with the hepatic diverticulum. And the larger dorsal outgrowths arise slightly cranial to the ventral extending to mesoduodenum and mesogastrium. When the buds eventually fuse, the duct of the ventral rudiment becomes the main pancreatic duct. So the main pancreatic duct from the buds which fuse with the ventral rudiment. And now we have a question about the annular pancreas and asking you which portion of the duodenum will be compressed by the annular pancreas. It most commonly will be the second part of the duodenum. And now, by knowing the embryological origin of the pancreas, this question is logic because you know that the ventral bud splits become bifid and the two segments may encircle the duodenum, which is abnormal because we all discussed the origin of the pancreas and we all agreed that it has ventral and dorsal bud. And now the problem with the ventral bud, which caused the obstruction of the second part by causing annular pancreas. The last thing I want to stress regarding the annular pancreas that it can be manifested with the newborn or the adulthood. So it can pass silent until the adulthood or present with the newborn. During newborn, there will be spit up more than normal and don't drink enough milk. You will be not eager to eat. In adulthood, there will be fullness after eating and nausea and vomiting, and I will take the vomiting notice for you to search either it's bilious or non-bilious. It's your duty to do at homework. And the symptom occur when the ring of pancreas squeeze and narrow the small intestine, which is the second part of the duodenum, as we agreed. And there are many conditions associated with the annular pancreas, like the Down syndrome and excess amniotic fluid during pregnancy, which is called the polyhydramnios, if you don't know, and other congenital gastrointestinal problems, and even peritonitis. So yes, annular pancreas can cause intestinal obstruction in neonate or adulthood. Take care. Again, annular pancreas may cause serious intestinal obstruction in neonate or adulthood according to the degree of compression of the second part of the duodenum. There is great surgeon. The gastrinoma most commonly found in the duodenum, up to 50% of the patient. And the next common site will be pancreas, with 20% of the patient will be in the pancreas. Other ectopic area will be the stomach. So gastrinoma is very confusing name, I know, because many will think gastrinoma like gastrin for stomach. No, it's mainly in the duodenum. Then the pancreas. Greater than 4 over 5 of the gastrinoma are found within the triangle bounded by cystic and common bile duct. Second, third part of the duodenum, bottom, and neck of the body of the pancreas median. The pancreatic carcinoma are normally solitary and highly malignant. The Zollinger-Ellison syndrome is composed of a triad of non-beta-eyed cell tumor of pancreas and hypergastrinemia and severe ulcer disease. The clinical feature related to the peptic ulcer disease diagnosed based on three criteria. The fasting hypergastrinemia, increased basal acid output, and secretin stimulated test positive. The management will be resection of the localized disease, if it's localized in fact. Dear great surgeon, you have to be aware that the abdominal wall layers continuation will be the scrotum to form it. And you have to know that from the contents of the scrotum that the dartos muscle is a rudimentary muscle, just like the platysma. They are not well developed in us, but they are very important and well developed in the animals to help them in shivering and removing the flies from their skin. So let's take layer by layer from the abdominal wall and it's corresponding to the scrotum. The skin will be the skin, while the scarbus fascia becomes the dartos and smooth muscle, while the external oblique fascia becomes the external spermatic fascia, while the internal oblique muscle becomes the cremasteric fascia and muscle as well, and the transversus abdominis as well as will share in the formation of the cremasteric fascia muscle. So the internal oblique and the transversus abdominis became the cremasteric muscle and fascia, while the transversalis fascia became the internal spermatic fascia. Remember that the external oblique fascia became the external spermatic fascia, while the transversalis fascia transversalis became the internal spermatic fascia. And at last, the peritoneum became the tunica vaginalis. So let's revise the fascia that are found in our body. Behind the rectum, wall dire, wall dire, while in front of the rectum will be the denonville. So wall dire, wara, denonville in front of the rectum. The septum fascia surrounds the lung, while the abdominal wall will be camber and scarbus, which are continuations. The scarbus will be the dartos and smooth muscle and fascia, while in the scrotum we have external spermatic fascia, cremasteric muscle and fascia, and internal spermatic fascia. We have the Zucker candle in the renal fascia. You have to be aware of it. It's very important to know the fascia name. It's a very common question in the exam and may come like direct question. And when you find a fascia that has many names like the fascia of the Zucker candle or Girotta fascia, which is the pre-renal fascia, you have to know them. It's a very common question, easy question, direct question in the exam, and you have to take it. Another important fascia is the Buch's fascia. Buch's fascia is the penile fascia. It's very important to be familiar with the penile fascia. Again, we face the applied anatomy of our knowledge. We all know that the pre-renal fascia is the Girotta fascia, and now we have been faced with a question asking you about the bleeding around the kidney will be affecting which fascia. Of course, it's the Girotta or the Zucker or pre-renal fascia. It's as simple as that. Direct simple question, you have to gain it in the exam. It's not hard. The scenario is so simple, asking you a direct question about the fascia around the kidney. Hematoma will be in which fascia? Of course, it's not the valdire behind the rectum, and it's not the nervii in front of the rectum, and not around the lung, which is the septum, and not around the penile fascia, which is the Buch's fascia. It's around the Girotta fascia, which is the pre-renal fascia. Another applied question asking you about a nephrectomy by a posterior approach. He asking you which rib will be encountered. He is asking you about the surface anatomy of the kidney. And we all know that the 11th and the 12th rib lie posterior to the kidneys and may be encountered during the posterior approach. And pneumothorax is a recognized complication of this type of surgery. That's why you have to be familiar and know that the posterior approach will encounter the 11th and the 12th rib. And when asking you about the hilum of the left kidney location, it's a simple clinically applied question about L1. So the hilum of the left kidney is L1. And the tricky question asking you about the right kidney, because we all know that the left kidney and the right kidney are not at the same level, because the right kidney is below and lower than the level of the left kidney, because the right kidney is affected by the pressure from the liver in the right side. That's why the right kidney is lower than the left kidney. So the 10th rep is more superior to the right kidney and will not be encountered posterior to the right kidney. The 12th rep is closer relation posteriorly. So you can find the psoas major and transversus abdominis as well as the quadratus lumborum and the medial arc ligament, while the right kidney is not having a 10th rep behind it. Dear great surgeons, the renal vessels order is very important frequent question recall in the exam. So remember VAP from anterior to posterior. VAP from anterior to posterior. When you are looking to the kidney from front, you will face the vein, then the artery, then the renal pelvis and ureter. So the renal vein at first, then the renal artery, then the renal pelvis and ureter. VAP. Very common direct question. And the trick will be, he will ask you from the posterior approach. If you look at the kidney from posterior, you will face the reverse of the VAP. You will face the pelvis, then the artery, then the vein. This is from the posterior approach. While from anterior, you will face the vein, the artery, and the pelvis. Take care. And when we mention the renal artery, we must revise that the renal artery rises from L2. Remember, superior mesenteric artery are L1 and inferior mesenteric artery are L3. I know it's a little bit early to talk about the measurement of the glomerular fertility rate, but as we are talking about the renal anatomy, let's talk about the glomerular fertility rate measurement. Creatinine is very famous to be measuring the glomerular fertility rate in practice, but take care. Creatinine declines with age due to decline in renal function and muscle mass. So, glucose and protein and para-amino hyperporic acid are reabsorbed by the kidney. So, the best, most accurate measurement for the glomerular filtrate rate is the inulin. Remember this until we discuss it in details later on. So, again, inulin is the most accurate measurement for glomerular filtrate rate. Remember it and keep it in mind until we discuss it again. Inulin. Take care. I know that the innervation of the viscera is not your all concern, even for general surgeon. I don't know why. They are like mechanic of the viscera. But take care, you have to be familiar with the innervation of the viscera. So, the greater splanchnic nerve arises from T5 to T9 and pass forward and downward on the side of the vertebral bodies. They pierce the crust of the diaphragm and then join the celiac ganglion. So the greatest splanchnic nerve usually synapses from the celiac ganglion. A very common question in the exam is regarding the transpyloric plane. The transpyloric plane of Addison is important and it's a constant landmark. That's why it's very important, even in the obese patient. It corresponds to lumbar 1, L1 vertebra. The number of important structure passing through L1 is very important. You have to revise them from time to time and remember it with every time. In the question, there will be a question about this L1 site. For example, the spinal cord end at L1 and origin of the superior mesenteric artery at L1, the hilum of the kidney at L1, origin of the portal vein at L1, gallbladder fundus at L1. So it's very important to be familiar with L1. As long as we talk about the transpyloric membrane and talk that it's at L1, let's be back to another important vertebral mark, like L2. So at L2, the head of the pancreas lies at L2 vertebral level, as well as the renal arteries. So, regarding the pancreas, it can be divided into head, neck, and body and tail. And it overlies the inferior vena cava, as well as the right renal and left renal veins, and the common bile duct. So all of those structures at L2 vertebral level. That's why the vertebral level are important clinically applied. It also related to the right cross of the diaphragm. A very important landmark to talk about is the inguinal ligament and the inguinal point. So, the femoral artery can be palpated at the mid-inguinal point. Again, femoral artery at the mid-inguinal point. This is halfway between the anterior superior iliac spine and pubic symphysis. The femoral artery lateral relation is the femoral nerve and the medial relation is the femoral vein. Remember it by oval. The posterior relation is a psoas tendon, and at this point you can feel it. So, the posterior relation of the femoral artery, which you compress your hand to feel it against it, you will press your hand against the psoas tendon at the mid-inguinal point to feel the femoral artery. So you are pressing against the femoral artery against the psoas tendon behind it. The femoral artery is a continuation of the external iliac, by the way. It passes through the femoral triangle, giving off the deep femoral artery and enters the adductor canal. And we talked about it before, and very important. It enters the popliteal fossa and becomes the popliteal artery. And the popliteal artery is the deep structure in the knee, in the popliteal fossa, while the most superficial structure is the tibial nerve. Isn't the anatomy amazing when you recall it like a tree? And the tibial nerve is the terminal branch of the sciatic, which ends as the tibial nerve as the common peroneal nerve, which bifurcate into superficial and deep peroneal nerve. Wow, anatomy is amazing. You have to remember it and enjoy it. It's your life as a surgeon. When we mention the mid-inguinal point, which is the surface anatomy of the femoral artery, not to confuse it with the midpoint of inguinal ligament, which is surface anatomy of the deep inguinal ring. Take care. The mid-inguinal point is the femoral artery surface anatomy, while the deep inguinal ring is found at the midpoint of the inguinal ligament. When you are talking about the inguinal ligament surface anatomy and the deep inguinal ring surface anatomy, you are talking about the inguinal ligament word, while the mid-inguinal point is a femoral artery. Hope it made it clear. The relations of the organs is very important, and when you revise them as a map in your mind by viewing an illustrative photo, it will be like a map, and you don't have to recall some hocus pocus or Harry Potter spells of anatomy in your mind. You will recall it like you are playing a game with your map. So, like the relations of the bladder. Superiorly, you will find the sigmoid colon as well as the small intestine, or the uterus in female, while anteriorly, of course, the symphysis pubis, while posteriorly, the rectum, seminal vesicle, and vagina or cervix in females, while laterally, the levator ani and obturator internus. It's very simple. You have to recall it like this. It's a map, not a record. Isn't it great to find yourself bounded by the ureter relation and anatomical surface anatomy since your undergraduate and pre-graduation and after graduation until your master degree and MRCS exam? So the ureter anatomy is very important. And when asking you about the entanglement of the stones of the ureter, he is asking you about the surface anatomy of the ureter. So let's revise it together. The abdominal portion of the ureter lies on the psoas muscle, which lies over the transverse process of L2 to L5 vertebra. So we are talking about from L2 to L5, 2-5, 2-5. This is therefore one area where the kidney stones may be seen on the plain film. If you are searching for ureteric stone, don't search in the whole X-ray. Just look for L2 and L5, and there you will find it. If you know it, you will find it. If you are not knowing the surface anatomy, you will not find it at all, because the mind searches for what it knows. The abdominal ureter crosses into the pelvis in front of the sacroiliac joint and bifurcation of the common iliac artery. The abdominal ureter enters the pelvis just in front of the ischial spine. When interpreting a plain film of QB in kidney stone, you will often lodge in one of the three areas where the ureter is narrowest. These are the pelvis of the ureter and the abdominal ureter and the pelvic brim and the ureteric orifice. Take care. Ureter is very important in the exam. In every exam in your life, you are asking about anatomy. Dearest great surgeon, take care. There's a big difference between the gallbladder blood supply and the cystic duct blood supply. This is a whole thing and this is another thing. The gallbladder is normally supplied by the cystic artery, which is a branch of the right hepatic artery. The cystic artery is formed within the hepatoduodenal ligament. The right hepatic artery is a branch of the hepatic artery. The gastroduodenal artery arises from the hepatic artery as well. And the hepatic artery is a branch of the celiac trunk, as are the splenic and left gastric artery from the celiac trunk. The cystic artery can be identified during the surgery as it lies in the triangle formed by the liver, cystic duct, and common hepatic duct. So again, the hepatic artery gives right hepatic artery and gastroduodenal artery, while the celiac trunk gives hepatic artery and splenic and left gastric arteries. Take care, very important. To sum up again, the cystic artery is a branch from the right hepatic artery. The right hepatic artery is branched from hepatic artery. The hepatic artery is branched from celiac trunk, and celiac trunk is found at the vertebral level, number T12. Very important to know the anatomical hiatus of the diaphragm and their vertebral level. Frequently asked it in the exam directly. Whatever the scenario, it will be a direct question. He is asking you about a high-speed car accident and the diaphragmatic injury. At what level would you expect the aorta to be traverse the diaphragm? This is a simple direct question, not related to the scenario, and you have to win it. So don't panic when you see a car traffic accident. All the questions in the exam will be a car traffic accident, but the question will be separate direct mostly. So regarding the aorta traversing the diaphragm, it will be at T12. And remember that the esophagus with the vagus traverse at T10, while the vena cava and the phrenic nerve at T8. Again, the aorta opening in the diaphragm, the aortic hiatus in the diaphragm at T12. And it transmits the aorta and thoracic duct as well as the azygous vein, while the esophagus and the vagi traverse the diaphragm at T10, while the vena cava at phrenic nerve T8. Now we are facing another question of applied anatomy, telling you about a 12-year-old boy riding a bike, forced a brake and suddenly land ouch on his perineum, on the crossbar of his bike, and unfortunately he has marked swelling in his scrotum. And he attempted to urinate after the injury and developed this swelling of the scrotum. So, what structures must have been injured mostly? Wow, this is the spongy urethra, by the way, because it became swollen when he attempted to urinate. So, the rupture of the spongy urethra resulted in urine passing into the superficial perineal pouch. The attachment of the perineal fascia means that the rupture of the spongy urethra may result in a swelling of the scrotum, penis, and subcutaneously into the lower abdominal bone. Take care. Very simple, yet asking about the applied anatomy. The spongy urethra.